Good morning.
So I'm blessed.
We're getting started a little bit late, but I believe we have some participation via the telephone. Who do we have online with us this morning?
Good morning, this is Celia Howe.
Thank you for joining us. And for purposes of the record, if we could just go through the dais and mention who is present. For the record, I'm Colette Peters, Director of the Department of Corrections and Chair of this work group.
And I'm Kelly Ballas. I'm Chief Financial Officer of the Oregon Health Authority and Vice Chair of the group.
Good morning. I'm Washington County Sheriff Pat Garrett.
Good morning. Fairborn Paksuraj, Director of the Oregon Youth Authority.
My name is Carl Miller from OSP and the Association of Correction Employees.
Senator?
Oh, Senator Jackie Winters, the instigator of this work group.
Norwood Knight Richardson, Senior Vice President and Chief Administrative Officer of OHSU and Vice Chairman of the Department of Psychiatry at OHSU.
Mary Botkin with AFSCME, Council 75, and co-conspirator with Senator Winters to get the work group going.
Hi there, I'm Chuck Sparks. I'm with the Multnomah County District Attorney's Office.
Great. Thank you, everyone. I appreciate everyone's attendance. Again, I know we're moving at a very rapid pace, so I appreciate you taking the time to make these meetings work. In particular, I'd like to thank some of the folks in the audience who have been working diligently to turn around our requests for information at a very rapid pace. I know that we have a handful of folks who have been doing nothing but this since the work group convened. So thank you, Mr. Hateful, thank you, Ms. Martino, and Ms. Garcia, who stepped out in particular. So we're going to begin this morning by skipping back to last week's meeting and respond to most of the questions that you posed from the work group. There are some items that we're going to take a little bit more time to get responses to, but Mr. Hateful, if you want to come to the table and walk us through those responses.
Good morning. For the record, Bill Hateful, Health Services Administrator for the Oregon Department of Corrections. There were some information requests coming out of the last meeting. If I can turn your attention to the slides just to follow along. There were questions around cost avoidance in other states, the financial impacts of California's receivership, both their health care costs and litigation costs, agency comparison of health care costs between Oregon Youth Authority, Oregon Health Authority, DOC, and I believe the counties. We have some information. We have not been able to pull together the county information as of yet. And then measurement methods of adults in custody's insurance enrollment during incarceration and upon release. Some of the other states, Jeff Van Valkenburg, DOC's general counsel, contacted some other states to see if there was a history of receivership. There's some mention of history with federal involvement, but no other record of receivership anywhere else. There was also a question surrounding recidivism rates for early release inmates in California. We did contact them in a very informal study on their part. Of the 3 strikers released over the last year under Proposition 36 found a low recidivism rate, but these offenders have only recently been released, and so there's really no long-term data yet. And then Senator Bates had posed some additional questions, which we will be responding to at the next meeting. So cost avoidance in other states. We have a quarterly meeting with California and Washington. That meeting actually took place happened to be scheduled last Thursday. And we had some discussion with them about what efforts they were taking in order to control their costs as best they could.
Mr. Hateful, for the record, those are monthly meetings that you hold, correct? There and about?
Quarterly.
Quarterly.
Yes,
okay,
quarterly.
Thank you.
So Washington, California both reported several strategies, health utilization management and automated data, specifically in Washington. One of the things that was noted during the call was that prior to engaging in a network similar to what we have, they were paying about 100% of billed charges at one point. California built and recently opened a 1,700-bed health facility in Stockton, California. They've developed a medical classification model and a staffing analysis to go with it. And then they have a quality management team that's led by Dr. Barnett in California. And we're going to be getting more information from them as we can get it.
Could you tell me what you mean by medical classification model? What briefly did that compose?
Specifically, they're trying to develop what who should be housed where, to some extent based on their medical needs. And then a staffing analysis to go with that to support where those inmates would be housed. And partly their 1,700-bed facility will be housing both medically fragile and severely mentally ill.
So this was for the purpose of triaging them to the proper housing?
Yes.
Thank you.
I think maybe appropriate housing, but also distance to necessary care. So, for example, they have a lot of outstation places that are not close to hospitals, and this is an attempt to get folks that are going to need that kind of care a little closer
to those.
Yeah.
Thank you.
Bill?
Could it be helpful to get actually a document that outlines the standards of what the grid that they use?
You can do that.
It would be interesting. When you look at the numbers, they have over 140,000 inmates in custody in California. So to see how a classification tool could narrow it down for a mere 1,700 would be fascinating. Mr. Sparks?
Is this 1,700-bed facility open now?
Yes.
How long has it been open and running?
You know. I don't. It has not been long. It was under construction after they went into receivership, but I'm not sure how long it's been open, but we can find that out for you.
And if I understood our question, is it a triage facility or a sort of an end-stage treatment facility, or both?
It's both, to the best of my knowledge. We didn't have a lot of time to talk specifically about the hospital, so whatever information anybody likes, specifics about the operation of that facility, we'd be happy to get for you.
Great.
The financial impact of receivership in California. In 2005, the receiver found a backlog of patients awaiting treatment, and spending rises due to patients' visits to outside health providers. And really, the California litigation was their prisons were so overcrowded, they had facilities to care for people, just not enough space or enough providers in order to see people in an appropriate time frame. In 2009, California contracted with a third-party administrator for off-site care costs that receded costs to the pre-receivership level. As you might expect, during receivership, there's federal directive about how you're going to operate your system, and you have to comply with that. And sometimes along with that come cost increases. They centralized utilization management and adopted an HMO model, was implemented, and their costs receded a little further. Their staff costs have gone up, and then the litigation costs continue. And we don't have specifics on this yet, but we spoke with Joyce Heo, Director of Communication for the receiver, and she's assured us that they'll provide us some financial data as soon as they can pull it together and get it to us. And then also, General Counsel to the Department, Jeff Van Valkenburg, has also reached out to his counterpart in California for some data as well. We were requested to do some comparison around healthcare costs. What you see on the screen are those costs between the three agencies on a per-person spend.
Just a question, without knowing details here. Why is the OYA cost per day so much more than just your DOC cost per day for the youngsters?
Maybe I can answer that.
Thank you.
Unless you want to. So really, it's at the very first glance, it's economies of scale, because you're talking about, facilities of 2,000 or 3,000 inmates versus a facility of 150 youth. We have one, and a lot of that cost is embedded in qualified mental health therapists that we have. We have a qualified mental health therapist in every living unit of 25. And in our special needs unit, we have 2 or 3 qualified mental health therapists. So that's, very high level broad. The second piece is that there is comprehensive psychological and physical examination done on every youth who comes into the system. The approach toward youth offenders is a completely different approach toward adult inmates. And, for example, allergies is not something that, in the adult world we worry about. In the youth world, we treat allergies and deal with it. Acne is another thing, as the youth is developing and, their self-esteem and confidence is based perhaps on physical appearance. That's why, again, much more resource intensive than adult corrections. And, I can go into more detail, the percentage of youth who come to us with sexual and physical abuse and the intense engagement that it takes to deal with those issues. So that's...
Thank you.
Sure.
Thank you.
It would be nice somehow we've got a grid, because the other one is the difference in what's causing it between the Oregon Health Plan and DOC, particularly with the Oregon Health Plan, that population. It may be a tad bit younger than the DOC population, but I expect in looking at the age spectrum, because those 65 and older would go into Medicare, not Medicaid. But it would be interesting to know what is the cost drivers between these two. Historically, youth are less, so what you're saying is that because of the higher emphasis on mental health and some of those that's driving your system to a higher cost. However, looking at DOC and the trends of your system actually having a lot more mental health, this one poses a real conversation. Mm-hmm. I just personally, I think.
And specifically, Senator, the difference between the 570 and the
570 and the
268.
268. And I think we can drill down further in having the systems to then talk about mental health.
Mr. Havel, do we have the variables that went into the 268 versus the 570? So do we know that for certain we were doing apples to apples?
Can I comment on that? I know that it's very, very difficult to do apples-to-apples comparisons because the structures are so different. I think that we can produce more granular detail about this comparison that would maybe highlight those kinds of differences that makes the comparison difficult. Whether
I guess the question I would ask is your mental health, alcohol and drug mental health cost embodied in your 268 per?
It is.
It is. So you're that
yes.
in your 268.
Yes. If it's a covered Medicaid benefit, it's in there. We have additional alcohol and substance abuse and mental health for those individuals who are not actually enrolled in the Oregon Health Plan, but for those enrolled in the Oregon Health Plan, it's in there.
Madam Chair? If, Mr. Havel, I know you will correct me if I'm wrong, so if I understand this from conversations with you and Mr. Van Valkenburg,
You have to
OHP has the ability to deny coverage on some things that we in corrections do not have the ability to deny.
That is correct.
And
Right,
so,
that's right.
Once you become a resident of the state by virtue of the court system, you have sort of superior rights to health care coverage for everything that somebody in the Oregon Health Plan would not have. Is that, am I accurate in that? Okay.
I think the other piece of this, there's more direct service that is here in DOC and the Oregon Youth Authority than there would be your contractual service in the Oregon Health Plan. So I think those variables are there. It's just how we, so actually this may not be a good.
It's sort of it's an exercise that really doesn't have any end.
Right.
If you want more detail, we could probably get more detail, but.
But we're comparing two different populations. We're comparing two different legal requirements,
Yeah, I was
medical
gonna say,
requirements.
I mean, the legal requirement is what we always stub our toe on.
Yep.
And this is a political problem without a solution. I mean, people can be cranky, all they want to be cranky about how much we spend on inmates. The solution is don't send them to prison.
That's right.
That's your choice.
That's right.
Mary's right, and I think there has to be some preamble to explain, because we do get this a lot on cost. How come the cost is greater? So you do have the issue of when you send them, that you're in a facility that court directs. That you do certain things, and so it's a captured community, and you cannot say, I will not treat. It's just like the issue with the hernias and what have you, and then you also have inside of that, embedded into that the Oregon Health Authority can actually control and say no to benefits, particularly through the HMO, that you can't through this group. So poses some real challenges, and then you have the older, sicker, the older population with the Oregon Health Authority is in Medicare, not Medicaid.
Right.
So I just think those variables need to be there so that when we talk about it, because we often get beat up a lot.
So, Senator Winters, you would ask then for a description of the variables so that when the question comes up, why the difference, at least we have a fairly concise way of addressing that.
Correct.
Okay.
Thank you.
Director.
Thank you, Madam Chair. The other question that would not be very easy to answer is, what is the impact of this expenditure on the future of these inmates? In other words, when you look at the recidivism rates at the Oregon Department of Corrections, it's my understanding it's amongst the lowest in the nation, if not the lowest. So, we are spending $570 per month, and I'm assuming that you're putting a whole lot more emphasis on mental health issues. What is the payback? I mean, when you look at that, it might seem like a lot of money. On the other hand, when you're talking about further victimization, what's that worth and what is that preventing? So how much is that lower rate of recidivism connected to the effort that you're putting into this? I'm not sure if there's an easy answer to that. But
Can getting to the mental health piece, would it be more accurate if those cost comparisons would be what happens in the Oregon State Hospital versus what happens through the Oregon Health Plan? Because in both instances, you're not talking about outpatient, you're talking about a system.
Interesting.
So the cost comparison may not be where you have mental health, a good one. The step up might be, but you actually have now inside of your facility where you are needing to have a structure similar to the Oregon State Hospital, which then your cost variable would be different.
Senator, we can work together to draw that out for the next meeting or the meeting to follow. Director Paksarash, thanks for your comments. We have been noted as having the lowest recidivism rate in the country. I think you're absolutely right. Our focus on alcohol and drug addiction and mental health is part of that success. As DA Sparks and I were talking before the meeting, there are just so many individuals that get sent to us having committed heinous crimes while under the influence of drugs and alcohol. And so we really do try to focus those who have the highest risk to reoffend with the highest need for those treatment services. And there's no doubt that that contributes to that $570 a month. But we hope that it also contributes to positive outcomes, because as you've all heard me say before, our top priority is figuring out how to get these offenders back into the community and not creating new victims when they do. Ms. Bodkin.
I think the only other thing that just needs to be said is that the $570 per month may very well be money well spent. Okay, I mean, I having worked with the Department of Corrections for 30-some years, I think you all do a great job. I think our members in health services do a great job. I think they get really frustrated at seeing the same inmate, every day for a cold. But I understand the limitations here. What happens when they get out? All the good mental health treatment that we do, all the good, drug therapy that we do inside the institution does not necessarily translate to a good transition once they get out and go into the Oregon Health Plan, where they have the right to say no when we did not. And so, I think that there is a question about how many folks who are released from the institutions are able to continue with good community-based services once they're outside. And I think that getting them on the Oregon Health Plan before they get out, I think all of those things are good. But it'll be interesting to see if long-term, if the good work that we do with them while they're institutionalized is transferred out into the community.
No, I think you make some really great points, Ms. Bodkin. It's one of the things that we did talk about last time, and I know you weren't able to look at the information online, and so we'll get that for you. But I think we are at an exciting point because we are a Medicaid expansion state, and I think our ability, and this is what we talked about last time, to have the CCOs actually reach in prior to them being released from prison really will help that transition be more smooth. I think you're right. In current day, there's a gap. There's a gap in terms of getting them engaged with a practitioner. There's a gap in terms of getting them the pharmaceuticals that they need upon release and transition back into the community. We hope that this will all be resolved now as we expand here in Oregon. I don't know if you have anything else you want to add.
I only to say that this is extremely important and has a lot of promise for improving the health of that population, and I'm sure reducing recidivism. And when they do reoffend, they come back in having received a continuity of care, and addressing particularly those high prevalence substance abuse issues and mental health issues on an ongoing basis. So.
Agreed.
Mary, in 3194 and the change in transitional leave, it's going to be, I think, very important that the inmate, the education that is required, that you're now going into a community standard of care, which is different than the standard of care that's inside the prison. And so, therefore, there is that individual responsibility, even though we're talking about expanding health care, still navigating the community, and with that help, will be different than what happens inside the institution. And hopefully, through that transition, that takes place. But, with us being an expansion state, I think that that's a very plus benefit that we did not have before.
Yep, I agree.
Agreed, Senator. Thank you.
Well, that's a nice segue into the next slide. Measurement methods of insurance enrollment. So just 2 points. One is inmates actually can refuse service while they're incarcerated. We don't force them to take treatment or receive medical care or mental health care. And I think the big development with the expansion of Medicaid specifically is the single without dependent coverage that didn't exist in Medicaid before, which affected a lot of people. So hopefully as the adults in custody are getting out and we're helping them get enrolled, they'll actually have coverage as they walk out the door. That's the intent.
Jay Sparks?
If I heard you correctly, an inmate can refuse care across the spectrum.
Correct.
Does that include active mental health issues? So that if an inmate is dangerous to himself or herself or others, that inmate cannot be compelled to take medication?
Correct.
Not without a court order.
Right.
Right.
You do seek court orders to medicate, I'm assuming. I mean, we do that, obviously.
Our lawyer's going to help us out here.
Thanks, Jeff.
For the record, my name is Jeff Van Valkenburg. I'm General Counsel for the Department of Corrections and the Department of Justice. No, that isn't correct. The case is Washington versus Harper out of the U.S. Supreme Court, and state corrections, county corrections have the authority to voluntarily medicate inmates under certain circumstances, and it's a very significant standard. It's a little bit higher, I think, than the civil commitment standard. The question is when and where you do it, and those are, to some extent, individualized treatment decisions that have to be made. The Department of Corrections has administrative rules governing its exercise of discretion on how it provides a measure of due process for those inmates, because it is a liberty interest under the Due Process Clause. So there are significant rights involved. So not at the county level, not the state level is that done routinely. It's each entity, the state hospital has its own policies and process, state corrections does, and as do the counties. So, but there is that ability.
Great, thank you.
And it's used very infrequently.
Yes, sir.
We are developing a tracking system. We're also actively working with the health authority. We actually met with them last week as well on processes for accessing Medicaid for outpatient inpatient stays. For inpatient stays, not outpatient. And then we're also developing a process to ensure adults in custody are enrolled prior to releasing into the community. The way it looks at this point, it's essentially a same-day determination where as long as they're incarcerated, they're not eligible unless it's an inpatient hospital stay. So on the way out the door for release, we would submit the application as they're leaving. There would be an immediate determination as to whether they're eligible or not, and then in a perfect world, they'll go out the door with coverage. But we're still working through the details with health authority staff. And through a cooperative effort between Transition and Release Division within DOC and Health Services, we're developing this tracking system to monitor, track, and report applications and their status. We're continuing to meet with Oregon Health Authority staff to develop both the inpatient portion for payment by Medicaid as well as a process for enrolling adults in custody prior to release. We're also working with the Health Authority and Cover Oregon to develop a system where the DOC can assist inmates in enrolling for those benefits prior to release and to determine whether they're eligible or not before they get out. So they'll know going out the door whether they're going to have coverage. The goal is they'll be eligible from the day they release, and we've repurposed a position to serve as the department's reentry benefits coordinator to help tie together with health services because we don't do release planning. We have some specific folks who work on that, but we have a release and transition department that's their sole focus. And this person will be responsible for collaborating with OHA and other parties to develop this process.
Bill, I had a question from one of our members about also coordinating with the VA. Do we do that as well? Because a number of, I don't know, I have no idea what the number is, but there are inmates who are veterans as well. And so, as well as coordinating with OHA, it would seem to me if we can transfer some of the health care costs to the VA, then we can give it to then we can send that bill to the federal government instead of to Oregon.
We're looking at that, and only making an assumption. I'm sure that is going to be part of the reentry benefit coordinator role, but we're basically fleshing that out at this point to figure out how that's going to work. I think Sean's been on the job about 2 weeks now, so as you might guess, we don't have everything completely fleshed out yet. But
Really?
yes, I know.
I'm sure.
I will say, Ms. Botkin, over the last couple of years, we really have, from a holistic veterans benefit approach, have really improved the connection that we have with those benefits before they transition out. It will improve now with this position as we focus specifically on the medical piece, because that population is growing. Since 2010, it's grown substantially, and so it's one that we're really focused on and paying attention to. The Governor's Reentry Council actually just approved focusing on that veterans population for transition and release for 2014. It's one of their top priorities.
I know that the last time I was at Snake River, when I was in health services, there was somebody from the VA there meeting with inmates. And so I just wondered how prevalent that was, or if it was a fluke. But I'm glad.
Prevalent.
Good.
Thank you.
Good.
Madam Chair, I have a question.
Yes, Doctor.
Mr. Hayfel, you said that there is a transition department, and particularly with people with substance abuse and mental health issues have been treated in the prison. Is there a process where in this transition, they get to meet their caregiver? Is there an assignment of a caregiver before they leave, or they leave and then they're left to find someone?
Sadly, I can't answer that for you. We're only involved, health services as a division is only involved in the release of the medically fragile and the mentally ill who are very fragile, who are going to need services and assistance to be able to live on the outside. Right. For the general releases, that's through the transition and release unit, and I don't have the specifics of that.
So for the ones that you mentioned you do have responsibility with, the more fragile, mentally ill and medically ill. Medically ill I can understand, but there's often this gap in the transition of the mentally ill to the community and those with substance abuse issues. And that gap can cause relapse very easily because they don't know who they have and they haven't established a relationship. So I guess what I'm asking more specifically is there an opportunity for community clinicians who in those fields of mental health and substance abuse to come and meet the patient and familiarize them? You notice I said patient, but because my focus is is on whether or not that health care can keep them in the community and progressing. So can they meet or they get to meet them after they leave?
Typically, it's the latter. They meet them after they leave. We have one person, basically a specialist, who works on the releases for the fragilely mentally ill who are going to need those services, and their sole role is to connect them with resources on the outside, whether it be housing, a clinician, prescription services, whatever they're going to need. That's what that person focuses on.
I would have us consider that even for the general population who have, or not fragilely mentally ill, but nonetheless have the diagnosis of recurrent mental illnesses, that we have some way of connecting people with the community, and that's where the distance of the prison from the community to which the person is discharged is problematic. And I know at the state hospital, often people will come from Portland to Salem to establish some sort of a relationship and let the patient there know who it is that they're going, and occasionally they'll get a pass to go look at that place. That actually helps the transition, and I don't know what the rules are regarding prisoners being allowed outside visitors or having passes, which I know might be problematical in a prison system, but it certainly would would I think enhance or decrease the recidivism rate and enhance the treatment going forward.
Doctor, I think that's in line with the Vice Chair's vision as we expand medication and have the CCOs reach in. Would you like to make that a formal recommendation from this work group?
Thank you.
I would.
Yeah.
Okay.
I think it's not just the CCOs reach in.
Right.
But I think parole and probation has a piece in this as well as we talk about this particular reentry back into communities. Because they, they also have the role of making certain things happen. So
That seems to me to be a really important link here, in that wherever the supervision is assigned in a geographic location, in a region that will be a coordinated care organization, and it needs to all tie together to accomplish exactly what you're talking about, Dr. Knight Richardson, and that is no gap in care. And so, this is what we're working together to try and make that happen. And the design is pretty elegant, and it just needs to, all the connections and linkages need to be made. And I think it's a very good approach that will help.
Thank you. Senator, just to be clear, are you making a formal recommendation that all POs reach in alongside the CCO reach in?
I would think that's important, because you know as well as I do that if the POs aren't on board, and we can come out with all kinds of prescriptions, but they too play a major role in what happens when the individual is returning back to the community, as well as understanding what the prescription, or prescriptions in this case, are. I don't think, because they still are in most cases, are the ones as to making certain that the individual is doing what they need to do in the community. And also, I think as we get further along in this, and my little head's kind of turning over as we deal with the issue of mental health treatment inside of our communities. I'm fully aware that not all of our communities are capable, or do they have things in place that will provide for the kinds of treatments that we talk about. We've talked about the need for 16-bed facilities in case something happens at people, and yet there are communities who say, not in my backyard. We're talking about individuals who are coming out of the institution, who've been in, some of them in forensics and what have you. So I do think that parole and probation really needs to be a part of this. Thank you.
Great. Thank you, Senator. And I would just recommend that the work group that recommends that we not only make those recommendations, but we actually track those outcomes.
Right.
Okay.
Well, and I think it's going to be I'm sorry.
No, you go ahead.
I think it's going to be very challenging for those of us who travel to Eastern Oregon regularly.
I didn't say anything about that.
No, I understand. But I think it's going to be very challenging when you can't even get a psychiatrist who's willing to work in Eastern Oregon, much less provide reach-in services to inmates who are not exactly the most desirable patient base.
And
just suggesting.
Just for the record, because this is being taped, it's required that the individual goes back to their county or their place of jurisdiction. So when you talk Eastern Oregon and other places in the state, not everybody comes from the metropolitan community, nor do they all come from Salem. And not all communities have the resources, and that's, again, I do think in tracking, however, it will also identify where some of the major gaps are and why.
Good. Thank you, Senator. I think you're absolutely right. Deputy DA Sparks.
Bill, what responsibility, if any, does the DOC have, once an inmate is released onto parole or post-prison supervision, to pay for that inmate's health care or any part of it?
Once they release from DOC custody, we do not pay for any of their care. Once they're released, we do send inmates out with 30 days worth of prescription drugs just to get them started, but that is really the last expense we incur.
So if an inmate leaves with a mental health diagnosis and a substance abuse problem, and that's known to the department, and the department, as a condition of post-prison supervision, requires treatment, is that inmate given the means to do that, or is that simply left up to the inmate to secure the treatment however the inmate may do that? Or however the parolee or post-prison supervision?
I'm sorry, I'm unable to answer that question for you. I don't know the answer.
So if I might, unless Sheriff, okay. So then if it was a requirement of post-prison supervision, then the supervising parole and probation officer would need to hold them accountable. And they would, that individual would be required to fund and pay for that care, unless there were benefits at the community corrections that community corrections could muster to support that.
May I also add that if the individual is eligible for the Oregon Health Plan under Medicaid expansion and this process for getting them immediately enrolled in a coordinated care organization, that would fund their treatment.
Thank you.
And I think that's the exciting piece, because right now, those that are eligible for Medicaid is very small, and now they're saying 99.9% of those releasing will qualify. Sheriff?
Thank you, Madam Chair. And as the Chair indicated earlier, I want to add my thanks to yourself, Ms. Martino, and your staff for being really responsive to questions that some of us have had in order to better understand the landscape here for those on the outside kind of looking in. And I have a question related to an email that was sent in response to a question I had last Thursday. And it related to a slide from October 28th where you conveyed the % increase in severe medical conditions over a 6-year period ending in 2012. And on that slide at that time, you represented that there was a 29% increase in providing Hep C treatment or Hep C services. And I asked what % of the total inmate population was provided that special health care for that condition. And it appears, if I'm understanding the data right, that % population that was provided care rose from 11 to 13%. Does that sound familiar or intuitive?
Without the slide in front of me, I'm not.
Okay.
I'm not sure.
Okay.
I don't know what the percentage of the population is that we treat for hepatitis C, because it's based specifically on the stage of the disease. We actually have an infectious disease physician that works for us that actually travels the state and sees specifically hepatitis C patients, others as well,
right,
but specifically focuses on hepatitis C.
Okay. Just going down the line, the different metrics, for example, HIV/AIDS, your October 28th presentation represented that increase to be 17%. When you measure it as a percentage of total inmate population, that was flat, less than 1%. Mm-hmm. If I understand the data correctly, the comparative for diabetes was 48% increase in your slide, but when measured as a percentage of total inmate population, it was a 2% increase. Respiratory treatment, 91% increase from your slide, but when measured as a percentage of total inmate population, that increase was 4%. The big winner from looking over the data was cardiovascular disease, up 21%. And you represented that as a 159% increase. So a little different metrics, but for me, the increase as a percentage of total inmate population, very, very minor increase to flat, except for cardiovascular, which was very, very significant. Again, it just helps me understand, really what you're facing there. So thank you. And if I misrepresented or don't understand the data from that email, just call me on it.
Okay.
Later next meeting.
Okay.
Thank you. Thank you, Chair.
Thank you. Okay, so our next agenda item is to review the early parole release for severe medical conditions. And Mr. Haefel, you're going to walk us through that as well. Thank you.
So the early parole release process is based on an Oregon revised statute, which makes allowances for early release due to medical conditions, severe medical conditions. And the Oregon Board of Parole and Post-Prison Supervision adopted a specific process which fulfills the objectives of the statute. So it's initiated by a request for consideration.
Do you want to draw their attention to?
Yes.
You
So
also
there's
have an issue brief before
Should
you.
be a briefing document included in your packet that'll have this in.
I think I got it.
So the request can come from one of the adults in custody, an institutional staff, a family member, a friend, or a community member. All cases are given immediate priority, and we do an in-depth review, verification of the alleged medical condition, verification of the sentence to see if they're eligible for consideration, solicitation of input from case judge and district attorney, and comprehensive facility reports including the following: current status, criminal history, program work misconduct history, victims, community concerns, family, and a medical transition plan that includes continued care. So we also look at whether they would qualify for Social Security and Medicaid and/or Medicare benefits, facility placement, hospital or hospice admission, transportation, coordination with family or whoever their caregiver may be, continuity of medical care to include equipment, and coordination with community corrections. Additionally, each case is reviewed by the DOC executive team, which consists of the Assistant Director of Operations, the Superintendent of the facility at which the adult in custody resides, and the Chief Medical Officer. They conduct a detailed review to determine if early parole or release is compatible with best interests of the adult in custody and the community. The director would then review that and make a recommendation to the Board of Parole, and the Board of Parole makes a determination and the final decision whether they're going to grant early release. So the two really limiting factors in terms of who can be considered for release are they must be suffering from a severe medical condition, including terminal illness, or elderly and permanently incapacitated in such a manner the prisoner is unable to move from place to place without the assistance of another person. Any questions on early parole release process?
How many in the last, I don't know, 5 years or annually?
Let's see. To the best of my recollection, in 2008 we considered probably 17. 3 were released. In 2009, 3 were released. In 2010, no one was released. And I believe in 11, it was either 1 or 2. I don't have the number right there.
Thank you.
And a number of them are, I don't want to say summarily dismissed, but immediately removed from consideration based on their sentence, for what crime they're convicted and their sentence.
I think we had 34 applicants.
Right.
17 met the
17
statutory
met the
requirement.
statutory, and then we ended up releasing 3. And I can tell you that to date, none of those who've been released are alive. Pretty much they're all terminal by the point they would qualify for consideration. And we have very few who meet the definition of elderly and incapacitated to the point where they can't move anywhere without the assistance of another person. Even a person in a wheelchair can move by themselves.
Any questions on this topic or recommendations?
Are we doing any, just like we do forecasting for our prison population, on this particular issue, are we doing any forecasting looking ahead? You know, we know that prisoners are getting older and sicker, and are we doing anything that would suggest 2020 that this is probably going to be the universe?
Mr. Hafel, do you want to take a stab at the senator's question?
At this point in time, we are not. It is really difficult to forecast who might become either incapacitated to this point where they'd be considered, or to forecast who's going to become terminal 7 years from now.
May not be terminal, but we can do an age forecasting, can't we?
Well, the criteria for elderly is, and I want to make sure I get this right because it's in statute, it's elderly and permanently incapacitated in such a manner the prisoner is unable to move from place to place without the assistance of another person.
And I'm looking over Mr. Hafel to Mr. Robbins to pose a question. Is age part of the prison population forecast? And could we draw some data? I know I'm putting you on the spot. And could we draw some data from that?
For the record, my name's Steve Robbins. I'm the budget manager for the Oregon Department of Corrections. As far as I know, our research department is able to break out age based on their forecasting, but the OEA forecast is not age-based.
Okay.
I believe that's the case.
Thank you. So we could draw that data out for you, Senator, and get that to you.
Yeah, because all states are looking at and wrestling with this whole geriatric issue. You know, it's not just a, you know, we're all, and it's all, you know, going back to the lock them up, throw the key away, and now we recognize in that particular approach that we're having older and sicker individuals in our institutions, both that have mental health issues as well as physical health issues, and therefore I would think that just from a planning tool, you want to begin to understand what our populations inside of our institutions are going to look like. You know, 10 years down the road and 20 years down the road, because that helps us to plan as to, you know, how we're going to deal with those population trends. You know, previous years, we looked at the younger population coming in, and they weren't staying in quite so long. Now that's not what our universe is looking like. So that's why I asked that question on aging, and are we going to begin to look at some trend lines just from a policy standpoint?
So it sounds like our research staff do look at that. We will draw that out. I'm assuming they go 10 years out. I don't know if we can go 20 years out, Senator, but we'll pose the question. Thank you. Now, before we move away from this early parole release process, we have had lots of conversations about this issue. Is there any recommendation that the work group wants to make as it relates to the early parole release process before we move on to the next agenda item? We don't have one yet logged going forward.
I just have actually a clarification question. Is this different than the recommendation which appears later? And it's similar. It's part of the discussion that the good senator has been helping us have here about, you know, an aging population and the perhaps the criteria that this working group might eventually recommend. Is that a different?
It might be, Sheriff, or I might just be missing it. I'm just not, as I look forward in the presentation, I'm not seeing a recommendation.
Sure, I think at the end of the recommendations, there's the very last item is geriatric release, and I had the same question about that.
Because I have just a couple of points to make on that. I don't know if that's different than what we're talking about.
It would be the same, and I did miss it, Sheriff, so please.
What I would want to at least articulate to the group is that geriatric release suggests as a recommendation one criteria, and I think it's much more than that. It's, you know, we have some questions that we either need to answer or at least acknowledge they'll need to be answered going forward. For example, what is the general age for which we would, or the state would consider a geriatric release? Is it 60, 65, 70, something else? What sentences would we initially think would be eligible for consideration? Would we exclude murder and some sex offenses or all sex offenses? What are the medical conditions for which we may attach to that criteria? The Pew suggests that dementia equals no public safety risk, and I don't think that I could universally endorse the concept that someone with dementia or arriving at a certain age would automatically mean they're no longer a public safety risk. Will there be a requirement that they have a minimum incarceration period before we would recommend an early release? Will there be an alternative nursing or assisted living home where they would reside, and will there be security there? And sooner or later, this path is going to cross with Measure 11 requirements, and so that'll have to be addressed at some point. There'll be a victim input we'll have to consider during that process, that decision-making process. And I think at the end of the day, that the person who is subject to release must be deemed little or no threat to public safety. And I think that decision-making authority has to be either go back to the sentencing court or at least have some significant say by the prosecutor.
Or could have some of the same kind of structure that we have with not on sentencing court, but with PSRB. I think it gives us some thought of how we can actually structure for safety of the community, that kind of thing. I see this as continued work.
Yes, Senator.
Because there's a lot of questions that I think need to be, but yeah.
Thank you. That's all.
Chair Peters, just to
Yes.
sort of follow up on what Sheriff Garrett said, I too, when I read the recommendations, I did not understand this commission to have yet made any sort of recommendation. So it sounds like that hasn't happened. It's a work in progress, and we're far from that point right now.
Correct. I think we captured it simply because Senator Winters had made a recommendation that we look at potentially expanding the existing statute. I didn't even note that we were thinking about a different structure or forum.
Well, I think, and I had a little conversation with Heidi, because our timeline is very, very short to get recommendations or in. There's no way that this body's going to be able to say, okay, we're up and running, and here we go. But I do think that this group, similar to what we did with the governor's executive order, we continued that work beyond the initial commission, and actually because we knew that we weren't going to be able to be completed, and this could be the same kind of process, that where there's still areas that are still of concern and there's still areas of need, that we continue the work of this body till we flush those issues out. So I don't think in any way that we will come out with some definitive, in some areas, definitive recommendation for legislation.
So for this recommendation, then, if I'm hearing you, Senator, that you're recommending that the early parole release is studied further regarding expansion, correct?
You know, this geriatric piece, yes.
Do the work group members have anything in particular that they would like studied that we can capture in this recommendation?
No, but it would be helpful if Sheriff Garrett would share with us his list, because that was a great list.
It was a great list.
Yeah, it was a really good list.
Thank you. I will.
Chair Peters, I first of all, I really appreciate Senator Winters' remarks, and again, Sheriff Garrett's as well in his list. I think that what I have not heard at all thus far is active involvement and consultation with victims and with communities who have ultimately had their courts and who've had the violations occur in the communities, and then the courts have sent these individuals stateside. So it seems very apparent that we need to consult with, obviously, those communities. We need to engage the courts before there's any sort of separate process releasing inmates. Obviously, you're going to have a lot of interest, a tremendous amount of interest, and the process, I think, to have legitimacy in the eyes of victims and in the eyes of law enforcement is going to have to be very transparent and accessible to everybody involved, so that it's not something that happens unilaterally. And I think that alternatives to release, I'm very interested in the California facility, that we may be able to realize economies by going to something that is at least nominally a corrections facility, but doesn't have the same requirement, the same lockdown requirement, the same staff to inmate ratio. You're going to have medical staff on a much higher ratio, but either way, since we're going to be paying for medical care, it may be that we are large enough, the DOC, to have a facility that will deliver these services while these inmates are still in custody, because you're going to have, there is a tremendous feeling that when someone, let's just take a serious, it doesn't have to be a sexual assault, it doesn't have to be a homicide, it could be a kidnapping, it could be a violent robbery, that people are given the assurance that they're not going to see that person out on the streets. And there's going to need to be a process. Frankly, the idea that 60 is elderly is pretty stunning to me, as I'm, within just a handful of years of that myself, and I really could not understand that. So we may need to further define that. And I don't want to monopolize the conversation here, but it's just that I think we need to look very strongly at court involvement, victim community involvement, law enforcement involvement in this process and in this setting up the structure. We need to have a careful look at alternatives, and I think we need to look at the experience of other states in terms of recidivism. I'm appreciative of the fact that there's a recall process, but But what concerns me is how often has that been needed, and what might trigger that, and what might people do? Because if you do it enough times, if you release enough of these folks, somebody's going to need to be reeled back in because they've done something bad again.
So I'll unwind that a little bit and start with a little bit of explanation around the 60. So those individuals that come into our care and custody are 10 years older biologically than their chronological age, if that makes you feel any better, for the lifestyle that they've lived, the lack of preventative care. So when we're treating someone who's 60, their body is actually performing as if they're 70. So I wanted to make that clarification. And I think what I'm hearing from this group is a strong desire that as we study this further, not to have a retroactive expansion. So truth in sentencing, that it would be for individuals that commit crimes post the statute being changed. I also think in terms of victim outreach and other involvement with the community, this was a very thoughtful statute. It was one that included that outreach that DA Sparks and the sheriff is talking about. So am I hearing from the committee that if there is any expansion, that we utilize this structure, this existing structure as is, or is the work group open to a different sort of structure as we study this going further?
I think the current structure, and I don't think that's in any way to be abandoned, but I do think that the discussion along the line as population, the geriatric population, and the fragile individuals and the mental health population, as all of this begins to evolve, to looking ahead. And I know Mary and I have looked, have thought for years, we need to maybe somehow look at how we address that fragile medical population, whether it is still inside of the DOC system, whether it is some other way of addressing that. And I think that's still, something that this group can continue to look at. And I think the questions of making certain, this one talks about release. I think in addition to that, there's another piece that I think talk about how we actually deal with it in DOC itself. And so I think they're two different things, actually. And so I think the one of what they're doing in Stockton, California, talks about what they're doing inside of the the California correctional structure, which is not about release, but how they're treating this population. So I think they're separate. Did everybody else think they're separate?
Makes sense to me, so long as we account for the issues that we've talked about today.
Yeah.
Thank you.
The only thing I want to add to this list that I'm not sure why it's not on here is the terminally ill.
I think they're using the word, well, we talked about it, but I think they're talking about fragile and terminally in the same breath.
I think the statute does include it. I don't think we were just very descriptive in the slide.
Okay,
I
think medically fragile issues are very different, or can be very different, from a terminal diagnosis where there is an end in sight for that inmate.
The statute says a prisoner with severe medical condition, including terminal illness, or who is elderly and permanently incapacitated.
Okay.
So it's in there.
Okay.
And I appreciate this conversation so much. This is a very complicated conversation. It's one we've had in the past and will continue to have now based on the recommendation. In Oregon, we utilize our prisons for individuals who have committed very serious crimes. And the elderly population that we have comes to us because of the long sentences. So many of them are Measure 11, many of them are sex offenses, and so this is a very complicated issue around crime and punishment and accountability. And I will draw on Mr. Hayfell's point, which is most often we spend an enormous amount of resource medically before they're terminally ill, right? It's not the hospice program that's the expense. It's the time and finances we spent trying to keep them alive. And so this conversation, I think, is an important one to have because we do have adults in our custody that are incredibly expensive. I will use the quadriplegic example again. An individual who is completely incapacitated, can only communicate by clicking, and costs the state about $50,000 a month. So there are examples where this may make sense, but in the broad sense, I think it's a very complicated public safety issue.
As a data person, we're able to actually talk about, let's take a population from 60 upward, and what that population is costing us in the NDOC.
The cost of the population 60 and older,
based
what
on
they
age.
cost?
Based on age.
We can calculate that for the off-site care costs.
Okay.
We can't necessarily
For the in-
right,
for the
because
in-
we have what our staff costs are and whether they're seeing the elderly, because we don't bill internally, so we're not using coding internally. But we can certainly get you the costs for external
for
care.
what?
Yes.
For external.
Okay, thank you. Great conversation. As a point of order, I will note that we're about 30 minutes behind schedule.
Good dialogue.
But great dialogue. So, Mr. Haefel, your responsibility is to get us back on track. How's that?
Yes, ma'am.
All right.
Next topic, therapeutic levels of care. This came up at the last meeting. This is kind of the model we use to determine what care we're going to provide. I won't read through the document for you. You can certainly read that, but I'll focus on specifically level 1 is medically mandatory, where if you don't take action now, there's going to be a bad outcome. Presently medically necessary is something that exists, is a condition that exists right now that needs to be addressed. And I'll jump to level 4, which is limited medical value. Again, as our Department of Justice General Counsel says, I can't tell you categorically that we would not provide a service in level 4 because we have to do this on a case-by-case and individual basis, but very rarely would we delve down to that level. Level 3, to be candid, is pretty much where there's a push-pull tension that exists, and the courts help us redefine what's medically necessary. And I'll refer to the previous hernia conversation. You know, everybody's had their own life experience, and if anyone's ever had a hernia, really the only way to cure a hernia is to repair it. And it's around what impact it has on your activities of daily life and the level of pain. And so there's this push-pull around where do you decide to repair a hernia? And the court sometimes help us redefine where that is. And so we exist in this area, in this level 3 category, where we're not practicing according to, out of a fear base, but out of a business base. What makes sense to do? What is the right thing to do? What's the right care to provide? But with an understanding that there is this other body that has some say-so over what we do.
Probably straightforward, that it's more cost-effective to go ahead and do it than to end up in court with, and particularly since we have prolific writers inside the institution who likes to challenge everything anyway.
Senator, in addition to having access to medical care, they also have access to the courts.
You have you got one of the best libraries, legal libraries in the institution. Is that very fair to say?
Yes.
Ms. Bodkin.
Stitches. Is there a reason why we can't have a physician assistant or a nurse practitioner do stitches instead of sending them out?
I wish I could
it's on
give
my
you-
list of things, you know?
I wish I could give you a yes or no answer. It depends on the injury itself.
Right.
You know,
What?
I know you'd like a simple answer. I wish I could give you one.
well, you know, I get simple questions. You know, I get pretty simple questions from our members working in the facilities. And you know what? I hear from our nurses all the time, I know how to do a stitch. I learned it when I was in school. You know, why do we have to send them out to the hospital to get stitches? And I promised that I would bring this issue forward, and I think that the use of a physician assistant or a nurse practitioner has a lot of validity and could cut down on costs. And I'm sorry if it leaves a scar. You shouldn't have gone to prison.
Okay, we'll have him look into that.
Thank you.
Thank you, Senator. Anything else on the therapeutic levels of care?
No, I almost feel obligated. I believe, Mr. Sparks, you asked a question the last time around what constituted
Thank you.
in the spread that we showed, the chart you were referring to, cardiovascular disease, and what constituted cardiovascular disease. I have a list if you'd like to hear it. If not, we can provide it to you in writing if that would expedite this.
That would be good.
Okay, in writing?
Yes.
Please. Thank you.
With that, I depart. Thank you.
Thank you, Mr. Hateful.
Thank you.
Thank you.
Steve. Mr. Steve Robbins is going to join us to talk about the Pew Healthcare Report and what the Department of Corrections response is going to be to that report.
Good
Welcome.
morning. Good morning, Madam Chair, members of the work group. For the record, my name is Steve Robbins. I'm the budget manager for the Oregon Department of Corrections. I've been asked to give the work group a brief overview of the verification process we undertook as we reviewed the 2013 Pew report entitled Managing Prison Healthcare Spending. When the Pew report was published, DOC immediately recognized that the results for Oregon didn't look right for healthcare costs in our prison system, and so the DOC Budget Office immediately undertook a process to verify what those numbers were and to see if they matched our current expenditure numbers as well. I want to make sure everyone has a copy of this or is able to see it, because we're going to go through this in detail here. This matrix represents our findings. The first set of columns, essentially on the left side of the slide in the light blue, are what were in the 2013 Pew report. The columns to the right represent what we believe to be correct numbers. And we're going to go through these in detail in just a moment. In 2011, Pew did contact DOC about this study. They informed us that they already had our healthcare costs for 2001, that they had received that information back in the mid-2000s, and that they needed us to simply verify the 2008 number. So at that point in time, that's what we did. We gave them a number of $82,523,000 for fiscal year 2008. So as we look at this matrix, if we were to just look at 2001 for a moment, you'll see there that the number that they had on hand for us for fiscal year 2001 was $14,222,000. Then what Pew did was, in an effort to compare apples to apples, they did apply an inflation factor to that number so that the 2001 dollars were equivalent to 2008, and that inflation factor brought the number up to $19.3 million. That broke down then on a cost per inmate basis to $1,769 per inmate per year, and then for fiscal year 2008, it was $6,094, which, as you've seen in the Pew report itself, is an increase of 245%. We then went and pulled, in our verification process here in the last few weeks, we actually pulled expenditure data from those two fiscal years, and those are represented up on the right side of this, which is for fiscal year 2001, $35.5 million, and for fiscal year 2008, 74.1. Now, obviously, when we see that kind of disparity, there's a concern. And so the first step we take anytime we undertake something like this is to look back at what were the assumptions that were used in the original numbers, what kind of methodology was used and what was included. Unfortunately, inside our office, we did not have any record of any numbers that we had submitted or any methodology that we had used in coming up with those numbers. So then the first place we went was back to Pew and said, okay, these numbers have been submitted. Can you help us with what you asked for in your assumptions? They directed us to the fact that the 2001 number came from the Census Bureau, and that it had been given to them from the Bureau of Justice Statistics. And unfortunately, the author of that report from back in 2001 has retired, and they don't have any record in their books as to what went into the 14,200,000 number as well. So now we're faced with a problem where we don't internally have anything that talks about what the specifics were in that number. They don't have anything specific that talks about what was included in their number. So at that point in time, we're faced with pulling the actual expenditure data right out of our systems, which we did all the way down to the transaction level in the last 2 weeks. So we looked at exact funds, exact transactions to figure this out. And our numbers continue to reconcile to the numbers you see on the right, the 35 million for 2001, the 74.1 for 2008. One of the things I would like to mention is that our current practice, anytime we do a survey of this kind.
Can I hold for 1 second? Celia, are you still on the phone with us?
No, but Trevor Belt is with Senator Bates' office.
Oh, hi, Trevor. Thank you for joining us.
Yeah.
Okay. Sorry,
Okay.
Mr. Robbins.
Sorry.
Go ahead.
Our current practice in the budget office is anytime we submit data for an outside survey like this, is that we save all of that information, including the assumptions, the methodology we've used, all the data that went exactly into those numbers. I apologize. I don't know why that doesn't exist for this. This was done before I joined the budget office, and we decided also to try and find the analyst that was involved in this to help us. And believe it or not, he's currently a missionary in Uganda right now. So we just don't have any way of getting to that. So absent that, we pulled these new numbers, and I want to just clarify for the record exactly what is in the new numbers that we have up there. These new numbers include medical, dental, mental health, and pharmacy. It includes all personal services, services and supplies and capital outlay dollars. It includes all on-site and off-site care. It includes all fund types, general fund, federal funds, and other funds. It does not include anything with community corrections in the number, and it does not include anything to do with alcohol and drug treatment, because typically that in our agency is not handled under the Health Services Division. So when we look and try and understand why would there be differences in numbers like this, unfortunately, as I mentioned, we don't really know, but we have to make some assumptions. I'm not sure if that $14.2 million number possibly was just one component of healthcare. It didn't include mental health. It didn't include pharmacy. I'm not sure what was included there, but we ran multiple different scenarios to try and match that number, and we never came even close. Our healthcare was considerably more expensive than that in 2001, so I'm not sure why that number is what it is. If you look at the 2008 number, that number did come from our office. We own that, and I apologize to the committee, and that we own that number. The only way we've been able to try and match that number is, just as a reminder to the group, we do budget on a biennial basis, and many of these surveys ask for fiscal year data. And we have multiple financial systems, and it's possible. Each of them name and define a fiscal year a little bit differently, and it's possible that that could have been there, but we tried all of those scenarios as well and weren't able to match those either. So I am very confident in the numbers that we have presented to you on the right. We've gone ahead and we've confirmed those not only internally, but we've shared them with the Health Services Division. They're in agreement with them as well.
Can I have a question going back to the fiscal confusion?
Yeah.
Because we do things to June 31, and the feds do it to
September, end of September.
And, you know, looking at between 74 and 82, whether that may be part of the problem, but I know that data comparison across the country is more difficult one, trying to get apples to apples and oranges to oranges, and it's a real challenge, and it depends upon who comes up with the assumptions and then what questions they ask of the various states. And it's not just here in corrections, it's whether we're talking about other program areas.
I guess I'd just like to reiterate again, for instance, we just did a survey for Vera Institute in the last few weeks. If you were to ask us about that information, we would have a thick folder for you that says exactly what we did and why we did it. And that's the way that we should operate and continue to operate going forward, but in this case, we just didn't have that. So,
my concern is that Pew will send this out everywhere, and people will quote this over and over, and then when we go into our budgetary hearings in a very few months,
we'll have to explain it again.
That we will, and we'll have to explain it slowly in single-syllable words several times.
Senator?
You have your chair sitting here. No, you won't.
Okay, thank you. So the bad news is
the bad news is that, and I think those of us who do budget understand that often national reports do not actually reflect are accurate to what's coming from states. And so I want to thank you for going back and restructuring this. That was what was more important, to where we get a more accurate snapshot of what's going on in Oregon. Because where it happens is from outside that gets a hold of the report. It's not those who work on budget here in this building and our legislative fiscal office. It's those individuals who are outside, and some of our advocacy groups who have a particular bent to say, well, we read this, and so therefore that must be gospel, and then we have to explain, well, no, that is not gospel. We rely on the agency and the data that have been compiled, and I really do want to thank you for the quick turnaround.
Great, thank you, Senator. And we will be reaching out to Pew to see if we can find some resolve and some correction to the data. We apologize for contributing to the wrong data, but the good news is that when we peeled back the information, it didn't defy what we were thinking was the management of our healthcare system. So thank you.
Madam Chair, if I
Yes, Chair.
could. Is it reasonable to interpret what we've learned, what you've learned and gone back and fixed, that particularly with respect to Figure 2 in the 2013 report that is a comparative graph of healthcare spending and its rise over the 7-year period, we really don't know if it's accurate, if any of it's accurate. Maybe the other 31 states are accurate. Is that true? I mean, we just don't know.
I think that's a good assumption. We face, I don't want to open a whole other can of worms here, but we face the same problems when it comes to cost per day issues around the country. Different states are including different things in there, and all of us when we receive requests for this data are asking for clarification, and we get the best we can and we submit it, but I think it's possible that the same thing could be occurring in other states.
And in your discussions with Pew, did you ask, or did they tell you whether or not the underlying data for any of the other states was also not available?
They did not share that with me.
Okay, thank you.
What I would like to see going forward in the future, because I think it's important, is that we talk about how we compare with other states. What's often not in cost analysis or cost-benefit analysis is where there have been policy changes that actually will have a fiscal impact. And so often we leave that portion out. We don't talk about how a policy actually contributes to or actually reduces budgetary impacts. And I've often thought that is a missing piece when we do cost-benefit analysis. Some of us happen to have on our wish list the ability for Oregon, similar to what they have in Washington, so that we can do a much better job of actually talking of our studies and actually getting at a better cost-benefit analysis as we go forward in our work. And that's a huge piece that's missing, because there's no way can we compare what we do, and I'm saying it for the record, What happens in Louisiana, what happens in Oklahoma, what happens in other states, and their policies are dramatically different from where we're going in Oregon, and then come up with a true comparison with that state.
I agree.
Just have to put that for the record.
Thank you, Senator. D.A. Sparks.
So my takeaway from this, thank you, Chair Peters, is that we've spent, and you have spent a tremendous amount of effort in the last 2 weeks knocking down a straw man. And that the Pew report, for all kinds of reasons, I think Sheriff Garrett pointed out, we don't know about the other states, but boy, they sure got it wrong with our state. Fair, is that an accurate statement?
That is accurate, and we contributed to them getting it wrong for Oregon.
Well, I guess I didn't really hear how that happened, because it sounded like they went to the federal government, who got it from a different organization, and
That's correct, and that's for 2001, the
Right.
2001 data. The 2008 data, that did come from our office.
Okay.
And that was unfortunately incorrect, or we're not able to duplicate the assumptions that were made there.
I understand. So, but at the end of the day, the Pew study really is not a terribly useful piece of, it's just not terribly useful. And it sounds like, as Ms. Botkin points out, we're going to have to spend some time explaining it away. But for purposes of our analysis going forward, it doesn't sound like we can really rely upon the Pew study, but we need to rely upon perhaps some of the general trends or issues it raises, but not the data itself. Is that your considered opinion, or?
Yes, yeah, I would agree with that.
Thank you.
Thank you.
And if possible, I'd like to overlay some of the policy changes that had occurred. You know, we can talk about the increase in medical costs based on aging population and what have you, but there's also policy implications that's always involved and embedded in this.
No doubt. Thank you. All right. Mr. Robbins, thank you so much. I appreciate your efforts behind the scene as well as in front of the dais. Next on our agenda, we have Mr. Doug Young, who is going to join us to talk about this notion of utilizing an existing facility that sits vacant in a different way, and the original intention of our Junction City property, and when that might be utilized. Welcome.
Thank you, Madam Chair, members of the work group. For the record, I'm Doug Young, new construction administrator for the Department of Corrections. Now I have to get to the right place. I've been asked to give you a brief overview of the analysis of the Oregon State Penitentiary minimum, used to be the Women's Penitentiary, and of the planned Junction City facility. In 1997, DOC purchased approximately 240 acres in Lane County, located just south of Junction City, as part of the department's long-term construction plan to safely house adults in custody as our prison population grows. The project turned into a collaboration with Oregon Health Authority as the state's critical need for new mental health facilities. The former state hospital in Salem was one of the oldest in the country and was rebuilt here in Salem, along with a second planned facility in Junction City on our site that is currently under construction. These two state hospital facilities are critical to the safety and health of the patients and to addressing the growing needs of mental health. When we looked at our needs for a special needs facility in Junction City in 2007-2008, the department put together the bed needs for our special special populations, and also the general population inmates to assist in running the facility and caring for those folks that needed care. It was in two separate phases. Phase one was a minimum custody facility that had mental health transition, residential programming for alcohol and drug, and general population inmates. The medium facility, which was phase two, approximately 1,260 beds, included a whole list of inmates, including medical infirmary and long-term geriatric care, medium custody, alcohol and drug treatment. To date, at Junction City, between 2007 and 2009, there's been about $50 million given to us to build the infrastructure for the state hospital facility and for the future DOC facilities. To complete phase one, which is the minimum custody facility, it will be about $89.2 million to complete our design and the construction of the minimum custody facility, which is scheduled at 532 beds currently. One too many, too soon. We build just in time for a forecast that changes every 6 months. Currently, we are 103 inmates above the House Bill 3194 adjusted forecast, which is 183 inmates higher end of the session forecast funded by the legislature. Whoops. There we go. We've also done a brief look at turning the Oregon State Penitentiary minimum into a medical infirmary
schedule
at approximately $15 million. We used construction cost data from our most recently completed facility in Madras, Deer Ridge, and looked at what we could convert that into. Currently, we're looking at about 53 high health needs or geriatric beds for that plan, and the look has been very brief, and it was in April during the session. The advantage of OSPM, the infrastructure's all there, water, sewer, street connections, all of those parts and pieces. The conversion of that facility into a special needs facility is something that would have to be looked at in detail as far as the architecture of that mid-1960s facility.
But the initial assessment is that it's very costly.
Yeah, it's about a $15 million, 10,000-foot look at it.
Okay, great.
Maybe I'm just missing the train here, but we were talking about the Junction City facility, and then for some reason I was assuming you were talking about converting a part of that, in other words, repurposing that, but it sounds like instead you're talking about a different institution, Oregon State Penitentiary Minimum Security. And which institution might that be? I mean, am I just...
It was the women's prison on State Street here in Salem. And it was then, when Coffee Creek was built for the women's facility, it was turned into a men's minimum facility.
Okay.
And that's the facility that was looked at in April, this past April.
And was closed in 2010 and sits vacant, DA Sparks, and the Junction City property is yet to be constructed. And so as we talked about the purpose of that facility, if and when it is to be constructed, the focus was, could it be that house a special needs population inside that facility? So you're not missing the train. It is two different conversations.
And I do, and if I could, Chair Peters, just one more question of Mr. Young. Thank you, by the way. The list of various special needs beds, is this a hypothetical, when we look at the various types of beds that you could introduce into the Junction City facility, is that with a cost of $89 million? Is that the price tag for those beds?
The $89 million price tag is for the bottom three lines, which is the minimum custody facility. It was phase one. The total price for the complete facility reported by Director Williams to the legislature was in the neighborhood of $450 million.
And is that for the facilities that was originally envisioned?
Yes.
So it would be a different cost, obviously, to introduce all of these beds into that facility? I'm understanding you correctly.
The original Junction City program design was for the special needs beds listed here. And that was estimated at that time, including all of the infrastructure, which has been funded, at $450 million. So in big round numbers, about $400 million to build the complete approximate 1,800 beds, mainly special needs facility.
Thank you for this panel, because you're getting, I think, individuals confused.
Yeah, no kidding.
Give us where the Junction City development is and where it goes forward in that timeline.
Based on our current population.
Based on our current
projection.
population.
Our current population projection, based on the October 2013 forecast, has the need, based on bed numbers, for the Junction City minimum beyond our 10-year planning window, so in the beyond 2023. It's a long ways out there. And the medium custody facility, the other 1,200-ish beds, sometime beyond that.
I want to, let's cut to the chase. Part of this is tied up in some conversation of going forward with Junction City. There is also the conversation with mental health and those who think we should have residential facilities. My question is, in looking at this task for this group, when do we expect, or can we expect, Junction City to have, I don't care if it's 10 beds, 20 beds, 50 beds, but what can we expect to happen in Junction City to address the special needs housing at Junction City?
So if I might, based on our current prison population, we will not need Junction City. We will not need Junction City for more than a decade.
Right.
So if you're talking about constructing Junction City to house special needs, as this work group has recommended, it would mean it would mean an additional cost that's not anticipated right now, and it would mean that we repurpose existing beds that we have today and make a concerted effort to build Junction City in advance of the population forecast need.
So when you say you're going to repurpose beds, what beds are you going to repurpose?
Ms. Botkin, that would be something we would have to explore based on legislative direction. We have been given no legislative direction to speed up the construction of Junction City. The only reason we presented it today is because this work group has been talking about the possibility of repurposing existing facilities to manage the geriatric and the chronically ill, as well as this whole notion that we might build a special facility like they did in Stockton, California, and we already had plans for that facility in the out years, and so we thought we would present that plan here today.
But there's been so much discussion in this building about Junction City and what have you that we need to take it off the table.
I just have one more question.
Yes.
I need you to go back. You said you needed 532 beds for special needs right now, right?
No, ma'am. The plan in 2007, 2008 was a 532-bed minimum at Junction City, with 325 of them general population. And that was based on the population forecast at that time.
Okay, and then your 103 inmates over 3194 forecast for what?
103 inmates over.
Who are those inmates?
I don't know.
Are those
That's
special
just
needs inmates?
That's system population.
So you're already 103 inmates over the 3194 forecast? Is that what I'm hearing?
Yes.
Yes, that's correct.
Okay. Thank you.
Okay.
I wasn't clear about whether they were special needs inmates or not.
That's just a general projection.
Okay.
Thank you.
Thank you.
Director Paksrecht.
Madam Chair, the notion of repurposing the existing beds, does that include spending $15 million at the Oregon State Pen? to convert that minimum for that 53 beds?
Thank you. That is a proposal, but it's not one that has been funded, nor one that we're moving forward with at this time.
So you don't need that to, when you say we're basically going to deal with this, that doesn't include counting that $15 million to be funded?
Correct.
Okay, thank you.
Thank you. Okay. Seeing no further questions, thank you so much.
Thank you, Madam
I
Chair.
appreciate your assistance. Pardon? As a point of order, we have just 10 minutes to cover about 20 minutes of information. Pardon? That's why you're saying be quiet? So, Ms. Martino, if you could come forward. We have covered the recommendation to date to some degree throughout the conversation this morning. But if we can take a look at this, and for the work group members, so that you're in the right mindset as we have this conversation, we have one more meeting on December 9th where we will need to formalize and finalize the work group's recommendations. And then my recommendation to the group is that as we write the report on behalf of the work group, that we actually engage in sharing that information with you electronically. We'll have to figure out through public records requests how that gets passed along and then back to the folks that are writing the report. But the report is due to the legislature in January in order to consider proposed legislation for the February 2014 session. Yay, Sparks.
I think Senator Winters expressed the sentiments that certainly I share, that the work of this group seems just to have started, and it's such a vast issue. I mean, certainly a preliminary report to the legislature would be entirely appropriate, but I guess I don't see us having a lot of answers. I really am just figuring out which questions to ask, and I think Senator Winters put her finger right on it.
And I will have conversation with the governor's office and leadership of talking about continuing the work in preparation of actually more definitive, where we need additional study and more definitive legislation going into the 2015 session. So, you know, that's part of my plan. That certainly, you know, there is a lot more work to be done, and we don't want to do a shoot from your hip piece. We want to actually, you know, say to the legislature, you know, this is what we've gleaned so far, but we think that there's more work that still needs to be done.
Thank you.
Thank you, Chair Peters. Thank you, Senator.
Madam Chair, members of the work group, for the record, my name is Christy Martino, and I'll go over the current recommendations we have to date. Of course, these won't include the recommendations we've spoken of today, but we will get those back out in draft form for everyone. You should have this on your presentation. I'll go through them on the screen as well. The list of recommendations so far: electronic health records that best fits the needs of the department is the first. We also have nutritional review of food and associated costs, provide healthier food choices through the commissary, track and measure healthcare coverage upon release, early mental health intervention to prevent incarceration, and that is a nod to the governor's 10-year plan and the spirit and intent there. Following on the next slide, we have the recommendation of proposed legislation to prohibit insurance companies terminating insurance coverage to those incarcerated. Review the healthcare impact regarding unlimited canteen and how change may impact safety and security of prisons. Legislatively mandated exercise programs, and that we spoke of quite a bit today, geriatric release.
And we will change that to match the actual statutory definition so that it will be the early parole release. So there isn't confusion that it's just about geriatric release.
Any questions about the recommendations that we have to date?
I have two questions. The first is on the second recommendation, the food review. Madam Chair, or someone could just describe what would be different than what you're doing today, because my assumption is there are regular reviews of nutrition, so how would that be different?
If I might, what I gathered from this committee is, and especially Representative Williamson, who isn't here, so I'll channel her a little bit. We often talk about driving down the cost of food in prison, and often that comes with some degree of nutritional sacrifice. The notion for further review is to look at those food costs and what nutritional value is there. I think that the department does a good job of reviewing the food costs on an ongoing basis. For the record, we spend about $2.32 every day on every inmate for 3 meals. That's the total cost of 3 meals. We have just asked the Association of State Correctional, ASCA, Association of State Correctional Administrators, thank you, to come to the state to actually do a review of our food costs, and it will include some nutrition, so the work group could actually support that ongoing work. I think there's a notion, especially from Representative Williamson, that while we drive down food costs, which is a good thing, we may be impacting healthcare costs down the road. And so better understanding those complexities.
And if I can add something to that, I mean, I think it's really important that we, you know, with the increase in diabetic issues inside the prison, it seems unreasonable to me that we would allow inmates to have access to high fructose candy on a regular, unlimited basis while we're treating them for diabetes. It seems counterintuitive to me that maybe we ought to limit the ability to get high fructose candy on the commissary while you're being treated for diabetes.
Thank you.
Thank you, Chair Peters. And then just following
Yes,
up, the
Sheriff.
legislatively mandated exercise program, I don't remember what the details behind that recommendation.
Oh, Sheriff, I think that was 2 meetings past, and there was this notion that we mandate 40 hours of work and programming inside our prisons. Should we consider a mandated exercise program for those that are incarcerated? And I think it was a very quick recommendation. I don't know that we spent much time on the topic.
Well, if it works for state employees, it ought to work for inmates.
And Madam Chair, members of the work group, I believe it was Senator Bates that brought the recommendation to the group.
Thank you, which is
You're
why
welcome.
it's looking not familiar. So it's a conversation I had with the good senator, and it wasn't here. Thank you.
And maybe we should ask the court or local, do we know how many or what's the universe of inmates who come into our custody that had insurance when they came in? My suspicion is that most of them do not. So I know this came from the county, so we may want to have a conversation with Claudia Black about it, but my suspicion is whether or not because the population that we're dealing with, my thought is, do they really have insurance?
I completely agree with you, Senator, that it's going to be more of an issue for the counties and the jails. I mean, we probably have 15 or more % of folks that walk in our front door are paying premiums on a current plan that goes out the window.
Yeah, so we need to have some conversation with the county, because I think by the time they reach us,
It's going to be less, yeah, I agree.
yeah.
Okay. Thank you.
Thank you.
Director.
I'm not sure to what extent this is possible, but it would be helpful to know what are the costs of some of these recommendations, along with
Fiscal
some of the
impact statement
benefits.
with them, yes.
And frankly, I mean, if you're making a recommendation, and if the legislature, I'm glad, our chair's part of this committee, but quite often, you get mandate to do something without any funding. So, if we're going to implement electronic health records, what does that cost? Where's the funding coming from? And what are the long-term benefits of having electronic health records? And the other piece is, as the Deputy DA pointed out, it's good to have some of these communities that will be impacted by this at least get their perspective. If we are compelling insurance companies to do something, what is their perspective? Because I'm sure there's a cost to that, and that cost ultimately will be passed on to others. So,
Great. Thank you. Any other comments or questions regarding the recommendations? All right, thank you.
You're welcome.
So our next meeting, as I noted, is December 9th. We will work to answer all of the questions that you posed today and some that were remaining from the last meeting. For proposed agenda items, I will tell you what I have noted, and please feel free to add to this. We'll, of course, like we have been doing, review current recommendations. We will review the questions that you have all posed and provide answers to those, remembering that that meeting is our last meeting before we develop the preliminary report for January. We are going to have a presentation from Don Russ from OHA, who's going to talk to us about one of our recommendations and the plan that this work group could support regarding transition to release from a healthcare planning perspective as we expand Medicaid. And then we will provide final recommendations and talk about plans for preparing a draft report for January and for legislative consideration in February. Anything else in the vast and quick conversations that we've had that you would like on next month's agenda?
What we haven't looked at, or we just assume that the current system with 14 infirmaries and what have you, how you delivered your services through a third party is adequate. I think we would be remiss if we did not somehow, whether we go forward to looking at as a system, we're looking at that we don't actually have to look at that particular system. I think that when I sponsored the bill, it was to look at the whole total health care delivery system in DOC. And so, we've taken pieces, we've talked about mental health and some of those, but I do think at some point, whether it's a part of the continuum, but at some point we need to say, okay, as a body, we think that this is the most cost-effective way that we're doing business in the state or not. We think these are some improvements that could help in the delivery of services. That's why you have Senator Bates and others that are on here in the Oregon Health Authority. We think that OIA might benefit from X or Y, and that's why I said that I think we just begun, but there's a lot more that I think that we need to address.
Great, thank you, Senator. And we ran out of time, I know, to walk through some of Senator Bates' questions. One of his recommendations did appear, as we talked about just a moment ago. But one of the things that he's requesting, Senator, is that we review the third-party health administrator and its efficiencies and effectiveness.
Was that Senator Bates?
It was, yes.
Well, I guess the only other thing that sort of is niggling the back of my mind is, can we do better by limiting the use of contract doctors and going more to a physician assistant and nurse practitioner model for everyday sick call, whatever? Is there a way for us to do that without, and I'm looking at Jeff, without opening ourselves to some sort of, litigation that would be successful? Any change, inmates are going to file litigation over. Okay? If we change the time of day they eat, they're going to file a suit over it. So, bar that, I want to know if there are things that we could do to change the way we deliver basic services in a manner that would reduce costs, that would not subject the department or the state to successful litigation or potentially successful litigation. Did that make sense?
Mr. Hafel, would you like to address this proposal? Just quickly noting that I'm keeping these folks 2 minutes too long already.
Yes, ma'am.
Thank you.
We do currently use, so institutions typically are staffed when they're built, and that staffing is seldom readdressed, even though acuity and changes in care may take place. So, for example, the penitentiary has 3 physicians and 1 nurse practitioner. We do utilize nurse practitioners in most of our facilities. We have, I believe, 1 physician's assistant that's part-time at Snake River, and we may end up, and we're somewhat going to use nurse practitioners and physician's assistants interchangeably, recognizing there's a difference in the supervision. but we are utilizing them across the system.
Great, thank you. Anything else for the good of the order? All right, again, thank you, everyone. I appreciate your time this morning, and we'll see you on December 9th.